Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hi, I'm Christian Baglini. I'm a nurse practitioner with Mass General Brigham Cancer Institute in Boston, Massachusetts. Welcome to this program titled The Nurse View, Evolution of Anti-HER2 Therapies in Gastroesophageal Adenocarcinoma. I'd also like to welcome my colleague Elizabeth Cruz, a nurse practitioner with Memorial Sloan Kettering Cancer Center in New York. Today, we're focusing on current and emerging HER2 targeted regimens, primarily for the first-line treatment of advanced or metastatic GEA. About 20% of patients with GEA have HER2-positive tumors. All patients with newly diagnosed GEA should be tested for HER2 status, along with PD-L1, microsatellite stability, or deficient mismatch repair, and Claudin 18. In GEA, HER2 is more common in gastroesophageal junction tumors, with 30% versus 20% of the mid and distal stomach, and in the intestinal subtypes.
And yes, HER2 testing in gastric cancer is usually very different than guidelines for breast cancer. The testing performed is to determine HER2 status, and it's called IHC or immunohistochemistry, and it's usually expressed in scores that range from 0 to 3+. The higher the score, the more HER2 is overexpressed. The test results are interpreted as negative, equivocal, which is IHC2+, or positive as IHC3+. In IHC2+ results, reflex FISH is needed to determine whether patients are HER2 positive or negative. And IHC3+ and IHC2+ ISH positive are eligible for anti-HER2 therapies. Christian, would you want to explain a little bit more about these regimens and how did they become standard of care?
Yeah, definitely. So let's first talk about the first-line therapies in HER2 positive, unresectable advanced or metastatic GEAs. This sort of separates into two categories. The first being PD-L1 negative, which means a CPS score less than 1. Those patients receive double chemotherapy with a platin and a fluoropyrimidine plus trastuzumab. In the patients who are PD-L1 positive, which is a CPS score of 1 or greater, they receive similar double chemotherapy with platin and fluoropyrimidine plus trastuzumab plus pembrolizumab. So, Elizabeth, can you explain a little bit how these sort of became the standard of care regimens for this indication?
Yes, absolutely. So a study called the TOGA established trastuzumab and chemotherapy as first-line standard of care for HER2 positive advanced GEA cancers. This was a phase 3 randomized multi-center international trial that consisted of patients with advanced or metastatic GEA. And it compared trastuzumab plus chemotherapy versus chemotherapy alone. The results indicated that trastuzumab plus chemotherapy improved overall survival by about 4 months in HER2 positive patients. The trastuzumab plus chemotherapy arm had a median overall survival of 16 months versus chemotherapy alone patients. They had a median overall survival of 11.8 months. The FDA approved trastuzumab in 2010 and it became first-line standard of care. More than a decade later, pembrolizumab was added for HER2 positive patients who are also PD-L1 positive with a CPS score of 1 or higher based on the phase 3 Keynote 811 trial. It compared trastuzumab plus chemotherapy versus pembrolizumab plus standard of care in advanced HER2 positive GEA, regardless of PD-L1 status. The addition of pembrolizumab significantly improved patient progression-free survival and overall survival. And when stratified results by CPS, they found that the benefit was limited to patients with CPS score of 1 or higher, which became the approved indication. Patients inevitably progress after trastuzumab, and we have one anti-HER2 regimen used in the second line, which is trastuzumab deruxtecan or TDXD. Approval of TDXD was based on a phase 2 Destiny Gastric 01 and Destiny Gastric 02 trials. Destiny Gastric 02 randomized patients to the TDXD or chemotherapy, and it showed that the TDXD arm had higher response rates and longer median overall survival and progression-free survival. More recently, Destiny Gastric 04, a phase 3 randomized trial, compared TDXD with ramucirumab plus paclitaxel, and it demonstrated that TDXD significantly increased median progression-free survival and overall survival. There were no increase of grade 3 adverse events with TDXD, but there was a 13.9% rate of ILD or interstitial lung disease or pneumonitis. Christian, I know there's a lot of interest in finding HER2 combinations that will deepen response in the first line and delay progression.
Yeah, absolutely. I mean, as you said, we have trastuzumab, which is typically in the first line for these patients, and then TDXD, but definitely a lot of interest in sort of investigating other agents. So after trastuzumab, other existing HER2 targeted agents were studied in the first line for GEA and have failed, such as pertuzumab and lapatinib. But more recently, several new or novel anti-HER2 targeted agents have shown promising activity and tolerability in the first line, one of which being zanidatamab, which is a bispecific biparatropic antibody. This drug targets HER2 at the same two sites as trastuzumab and pertuzumab, but in one drug. This is approved for second-line treatment of biliary tract cancer, but not GEA. Just of note, it is furthest along on the development for the first-line treatment of GEA. So TDXD is an antibody-drug conjugate. Disitamab vedotin is an antibody-drug conjugate. Works differently than TDXD and is approved in China as salvage treatment in GEA. And then finally, HLX22 is a monoclonal antibody currently being studied in combination with trastuzumab. We'll first look at the Horizon GEA-01 trial. This was a phase 3 trial of first-line zanidatamab plus standard of care. It was patients with unresectable, locally advanced, recurrent, or metastatic GEA with HER2 positivity for central testing, ECOG performance status of 0 or 1, no prior treatment for locally advanced or metastatic disease, and no prior HER2 targeted agents or immunotherapy. This study was randomized 1:1:1 with a fairly large N of 914 patients. If you look at the different arms, the first arm, arm A being standard of care, was trastuzumab plus chemotherapy. Arm B was zanidatamab plus chemotherapy. And then arm C was zanidatamab plus tislelizumab, which is an immune checkpoint inhibitor plus chemotherapy. So all three arms receiving chemotherapy, the second two arms receiving zanidatamab, and the final arm receiving immune checkpoint inhibitor therapy. There were dual primary endpoints, which were progression-free survival as well as overall survival, and then selected secondary endpoints as well. Interim analysis was presented at ASCO GI in January 2026, so fairly recently. And what they found was a significant 7-month increase in overall survival and a 1-year longer duration of response with zanidatamab plus tislelizumab plus chemotherapy in comparison with the standard of care. They found median overall survival with zanidatamab chemo was numerically but not significantly longer than overall survival with standard of care. They also found a significant improvement in progression-free survival with both zanidatamab regimens, so arms B and C, when compared to the standard of care. And one thing to note is there was more toxicity with zanidatamab tislelizumab regimen with a higher rate of treatment-related adverse events, grade 3 or higher. And looking further, Destiny Gastric 03 trial. This is a phase 1B/2 single-arm trial. The results were reported at ASCO annual meeting in 2025. This was looking at TDXD with the higher dose of 6.4 milligrams per kilogram body weight, plus chemotherapy plus pembrolizumab. And the second arm T-DXd at the lower dose of 5.4 milligrams per kilogram body weight, plus chemotherapy plus pembrolizumab. The median progression-free survival was 10.3 months in the 6.4 milligram dosing arm and 9.8 months in the 5.4 milligram dosing arm, so fairly comparable. There was, however, a lot more toxicity observed with the 6.4 milligram dose, which I think is very relevant in the nursing role. And there are, just to note, ongoing first-line trials of T-DXd regimens, including 2 phase 3 trials that are comparing the T-DXd regimens with the current standard of care. Finally, if you look at the DV trials out of China, so looking at disitamab vedotin, which, as we talked about, is an antibody-drug conjugate, which works differently than T-DXd and is approved in China. So this data was presented at ASCO annual meeting. And what they found from the study is that efficacy in both DV arms was superior to efficacy in the arm that did not include DV. And there was a manageable safety profile. Lastly, looking at HLX22, which was a phase 2 trial, randomized arm 1 receiving HLX22 with trastuzumab and Zelox, the second arm receiving placebo plus trastuzumab plus Zelox. The median overall survival was numerically longer with HLX22, but the difference was not significant. They did see improvements in median progression-free survival and duration of response with HLX22, which did not reach significance, however. So, Elizabeth, turning back to you, maybe I can get a little bit of your thoughts about sort of looking at this data and considering what are the implications for nurses who manage patients with advanced or metastatic GA when we look at the data as far as everything, looking at both efficacy, toxicity. What are the things that we need to consider?
Yeah, definitely. Thank you for that data. Nurses, as we know, are an integral part of the clinical team. They definitely need to be educated on the safety profile of the anti-HER2 regimens and how, the different regimens in combination with standard of care and their side effect profile. To be able to talk to patients about their options is super important so that patients feel comfortable and there's repetition right from the clinician and the nursing staff so that there is a clear understanding of the different regimens available and understanding how the safety profile of these regimens differ from current regimens is super important so that we can prophylactically treat symptoms and promptly identify them.
Yeah, absolutely. We've talked a lot about these different HER2-directed therapies, but I think what we also need to consider is that they're being given alongside other agents. And one big thing, especially when we consider first-line treatment, is the addition of pembrolizumab. I'm not going to say it's changed entirely how we approach these patients, but it's definitely just another layer, another factor that you have to consider, especially when you're looking at toxicity, because there's going to be overlap with a lot of these different therapies. The same can go for standard chemotherapy. You're going to see some overlap, and there's also going to be some ambiguity around what drugs may be causing which potential toxicities. So I just want to throw that in there as well as something that I think is definitely to consider in the nursing role. Let's look at zanidatamab from the Verizon GEA trial. The big thing with zanidatamab is the GI side effects, by and large. You can see that in the first 3 most commonly reported toxicities: diarrhea, nausea, vomiting, with diarrhea being certainly markedly higher in both zanidatamab arms. Similarly with grade 3 or higher. And then similarly also with GI, you see decreased appetite, you see decreased weight. The platelet count and the neutrophil count was less affected with zanidatamab, which is sort of intriguing, but just points out how the toxicities between the different HER2-directed agents can be so variable. Also, with blood counts, maybe not having to worry quite as much. Certainly keeping an eye and monitoring routinely, but not having as high of a concern. So diarrhea, biggest concern with zanidatamab. Prophylaxis was mandatory in the trial in both zanidatamab arms. They used loperamide, 4 milligrams twice daily for the first 7 days of cycle 1. And really the reason for that, onset of diarrhea is generally within the first week and resolves within a couple of weeks for most patients. However, it did lead to discontinuation of drug in about 5 to 8% of patients in zanidatamab arms. If you look at the actual rates of diarrhea, quite high for any grade diarrhea, 82% in the 3-agent combo, and then 76% in zanidatamab plus chemo. And 25% of grade 3 or higher is pretty significant. So diarrhea, as I've probably harped on too much now, definitely something to keep a close eye on.
Yeah, and to kind of piggyback on the diarrhea topic, any treatment-related symptoms like diarrhea, whether it's with zanidatamab or any other treatments, intensive education And checking in with patients frequently, I think, is very important. And just to even define what diarrhea is, right? When we interview patients, sometimes we may have to reevaluate, okay, what are they experiencing? I think defining what diarrhea is and making sure that everybody understands that is important, because that will help patients to identify when their symptoms are getting out of hand and to promptly report them. Like mentioned before, loperamide 4 milligrams twice a day for about a week was recommended with zanidatamab. As well, I would recommend, diet related interventions like the BRAT diet, electrolyte rich fluids, and working closely with your clinical team to check in with the patients, especially that first week of treatment, so that we can really manage those symptoms. If symptoms are not improved or managed with loperamide, we can quickly escalate to other antidiarrheal medications that can be prescribed, or make adjustments to their treatment. I also recommend for patients to keep like a journal or a calendar to determine the onset of symptoms and how long did the symptoms last, and the frequency. It really will make a difference when we clearly can obtain that data from patients. I review with patients and their family members to report promptly side effects that are not managed within the first 24 hours, so that we can prevent any serious outcomes.
I love so many things of what you said. The important thing that I really liked was defining diarrhea because, working in really the medical field in any capacity, we just take our understanding of diarrhea for granted. But patients hear that and they may just think like, oh, it's just a nuisance. But I think defining diarrhea and then explaining why it is that is significant, how it can lead to dehydration and can lead to electrolyte imbalances and cause all of these sort of downstream negative effects that can be life threatening in cases. I'm sure you've seen it. I know I've seen it. And so telling people that's why it's important to aggressively manage the diarrhea.
To have a standard definition of diarrhea, it's defined as three or more loose watery bowel movements within a day. And that's important, like you mentioned, to reiterate that, because some patients would say, yeah, I had diarrhea. And when you explore it further, it was just one loose bowel movement. What I tend to do also is assess what their baseline is, and make sure that there's no changes above that.
Yeah, absolutely. That's another piece. Same thing. I always ask people their baseline. When you talk to patients, the experiences are going to be different. The reporting is going to be different. People's willingness to tolerate diarrhea varies. That also gets into the nursing role of where it's important to be a partner with the patient and say, we want to know everything. And just know it, we're not going to do something that will inappropriately affect your treatment. I think for a lot of folks, that's their concern, right? They don't want to tell us about the diarrhea because they don't want us to change treatment. I think that's where it's good to have that sort of therapeutic relationship. The other thing is, considering other conditions or drugs or whatever it may be that can cause diarrhea. When we look specifically at GEA cancers, consider the fact that some of these patients will need enteral feeding. And I've certainly had cases where patients are starting therapy, they've just had a feeding tube and they're not yet in a place where they're tolerating it well. And so they're having diarrhea and GI side effects. And that's going to just sort of accumulate on top of the side effects of treatment. So looking at other factors as well, I think is really important.
Absolutely. And as you mentioned, right, reassuring patients that decisions are made using shared decision making, tools. It's a partnership. It's not like what we tell them to do. We have to communicate. It's a two-way street so that we can keep them on the treatment, make sure they have quality of life, and make sure that they are able to tolerate it, have that balance.
Yeah, absolutely.
With HER2 therapies, infusion reactions may also occur when they're receiving their infusions. I reassure patients that it can be from mild to severe. It doesn't mean that it's going to happen with every infusion, but I, again, review what that may look like and that it would happen when they're receiving the drug. And symptoms can include anything like itching, flushing, changing in breathing, acute abdominal pain, or even back pain, and that they should say something. And then, I reassure them that if this were to happen, there are interventions during the infusion. They will get pre-medications to minimize this, and even future infusion can be extended to minimize infusion reactions. Other side effects that are possible is interstitial lung disease or pneumonitis, which is basically inflammation of the lung tissue. This is not very common, but just to raise awareness of the nursing team and the patients that if they were to develop like a cough or changes in their breathing, it is super important that they mention this. And as clinicians, it's also imperative that we review the imaging because even like mild ground glass opacities can be confused for pneumonia, but it could be the early stages of pneumonitis. So it is very important to keep that in the forefront of our mind so that we can catch things early on. Nausea, as mentioned before, can be a side effect that can be very debilitating. So we, again, re-educate patients that they will get pre-medications with their infusions. I oftentimes ask patients what has worked for them in the past and review things that we can add to the regimen. It's a trial and error, right? Just because they tried one medication or anti-nausea medication once doesn't mean it's not going to work again. It's, again, a conversation that is reviewed in multiple visits so that we can make sure that their nausea is well controlled. And lastly, HER2 drugs are known to cause cardiotoxicity. So we always baseline obtain an echocardiogram to check the left ventricular ejection fraction. And then we recheck it every 3 months. Tell patients if they have any ankle swelling, any shortness of breath, any unexplained weight gain, they should report it to us, to the clinician and the clinical team.
So, taking all this in whole, how do we think about keeping the patient central in terms of adverse event management? We know that nurses have disproportionately higher communication opportunities with patients when you compare them with other healthcare providers by nature of the fact that they're providing that hands on care. This is a tricky topic, right? Cultures can vary by institution, but it's still a fundamental role of the nurse to be the advocate for the patient. I could have three separate conversations with the same patient in the same day and hear three different stories of the adverse events they're experiencing. But this just points out that nurses who spend the most time with patients, they're the most likely to probably gather most of the story. And patients don't always know, as we talked about, what is considered a significant symptom or a complaint. And it's for this reason that nurses need to be informed on possible risks and toxicities so that they can identify early red flags of toxicity. For instance, if, like you just said, Elizabeth, during an infusion, a patient mentioned weight gain and maybe some shortness of breath or cough or whatever it may be, and you ask, oh, did you tell your provider this? And they say no. It's a responsibility to tell the provider and to make the team aware. It's never wrong to over communicate. The key is to communicate in a way that fosters collaboration. I think that's really the key here. We all have competing interests in our day to day, and we have busy days. So having these checks and balances is important, and it's part of what makes healthcare teams successful. And on the same note, it's important to empower patients. I like to do two things when I talk to patients. One is ask them how they gain their knowledge best, whether it be from printed resources, virtual resources, just talking about it, and then provide ample resources based on how much information they may want to know. I also like to ask them if they have a support person or a caretaker that they want to have this knowledge. This not only helps the patient to be better equipped, but it actually can help to sort of promote a better partnership with the patient. It creates a more seamless, efficient model of care, and I think helps everyone in the long run. Elizabeth, could you tell me about some challenges, successes that you've had in a clinical setting?
I think, going back to one of the main side effects of the GI, like diarrhea, that's why I kind of emphasize defining diarrhea, how important it is. Some patients don't feel comfortable talking about, their bowels or bowel movements. And I have had patients that have a really hard time describing what their movements are like and how often it occurs. And, I kind of find it challenging sometimes if they're not able to report those symptoms adequately. But those patients that are very detail oriented, sometimes they're just so overwhelmed that they don't remember the interventions we provided. So I find it challenging because, if we gave them a printout, if we reviewed it verbally, have to take the loperamide twice a day, and they're not feeling well, then we're not able to optimize their care. But I have learned that frequent touching base with the patient and being able to support them and reviewing things with them and reassuring them that it is okay to take the loperamide twice a day, that it is okay to eat the brat diet and other fluids to manage your symptoms. And then when we successfully manage their symptoms and they feel better, then that challenge of being overwhelmed and not being able to remember those instructions kind of really dissipate. That was a very general example, but it just kind of captures when patients are overwhelmed and it's hard to remember things. And like you said, I always encourage, like, do you have somebody that, a second pair of ears that can be here or I can call so that they can remember, or a note taker? Like I had a patient bring in, oh, she's my note taker. And I said that's extremely important because you can go back and review things and it will make it a little easier and reassuring.
Yeah, absolutely. I certainly have had very similar situations. When I'm thinking about, these HER2-directed drugs, there's one recent case of mine that comes to mind that I'll just talk about a little bit broadly. It was a gentleman with GA, advanced metastatic disease, HER2 positive, started chemotherapy with trastuzumab. He'd required enteral feeding to start because of progressive dysphagia. Within days of starting treatment, actually had improvement in oral intake, was able to eat again. And so he asked for his tube to be removed, which was great. And he did well for many months on treatment. We talked about earlier, patients typically progress at some point. And so that point came for him where it was not radiographic on scans, but it was clinical. He started to have recurrent dysphagia. And that progressed quite rapidly. And so we had to look for it endoscopically. We rebiopsied because we wanted to confirm the HER2 status, which we did. And we started him on second-line TDXD. At that point, he did unfortunately require TPN actually, because they couldn't place another tube. And so I think that the challenges of that are that you have these patients, we talk about other factors that are going on. So there's the enteral feeding, there's the weakness, there's still the side effects of the treatment that he's on. And then there's the recurrent hospitalizations. Thankfully, we started TDXD and same thing, within days, he was able to eat again. So I think that's the success, right? It's like you have these really challenging cases, but you see the benefit of having these HER2 therapies where patients can respond really well and have good outcomes. I bring this up because I think the piece to bring up is, it requires working in teams, especially with the dietitian in his case was very important. Working with the inpatient team to make sure that you had a good sort of transition plan was important. And then working with the nurses. I rely so much on the nurses that I work with to help with communication and collaboration and just continuity of care.
Thank you. Thank you so much. That is very common scenario and very good in illustrating benefits of HER2 therapies. To conclude, novel HER2 agents for first-line treatments, as you just mentioned, and second-line treatments are very encouraging and exciting and provide us with, good benefits. There's always new learning curve with new therapies. And to reiterate, a proactive multidisciplinary approach that combines patients reporting their outcomes, personalizing the care plans for them, and collaboration among the team is the best way we can optimize symptom management. Ensuring that our clinical team, especially the nurses that spend so much time with our patients, are familiar with the efficacy and safety data is important so that they can successfully communicate the different treatment options and how they work. Because when, as nurses, we understand how treatments work, we really can educate our patients and manage symptoms. And then educating patients about adverse events, what we spent a lot of time on, is especially important because it prompts detection and proper management, which again can improve their quality of life and allow them to stay on treatment for as long as possible. I want to thank you, Christian, for your expertise, sharing your experiences, which is invaluable.
Yeah, thanks, Elizabeth. I think this was a great sort of discussion about the comprehensive nursing role and looking at data. And I felt like this was really helpful just to remind myself about, also why it's important to do these things, but appreciate your insight.
Absolutely. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.